Hello, everybody. Welcome to Mammography Educators' first Instagram Live. This is major for us, and I'm so grateful that we're going to be having Louise Miller on today to be talking about avoiding injuries. Ergonomics is wildly important for radiologic technologists and anyone in the mammographic field. Hi, Deb. How are you? Look at all these amazing people coming online. Thank you all so much for being here. We're so grateful to have Louise on today. And she just never ceases to amaze me. And it looks like we have some people that are interested to come up in the room. But what I'm going to tell you is to please just drop your question. Just a little bubble on the bottom with the question mark. You can leave your questions there. Hello from California. Hi, Louise. How are you?
Baby down?
Yes, fast asleep. So we got plenty of time and energy. You look wonderful today.
Well, thank you. I tried to find something different. I'm in my living room now instead of sitting with my
refrigerator.
My head.
Well, it's so good to see you. And like I was just reminding everybody, if people are interested to ask you questions directly, to just drop them into the question bubble, and then we will get to them at the end after we, go through all this amazing information. So first of all, everyone knows you. But for the people who are new to our channel and new to you, do you want to just briefly, give a little introduction?
Well, I first would like to clarify that I am the one and only mammo queen.
Undisputed.
There are imposters. If nothing else, I win it by default. I am the oldest and been around the longest. So.
Right.
But those of you who know me know I have been teaching for over 30 years, dedicated almost, I want to say, my life to trying to promote the expertise and professionalism of mammography technologists, because I don't think enough people realize how important our role is. So obviously education has been a huge part of that, and I just had an incredible opportunity to work with so many of you, not only in this country, but in Canada and all over the world. So I hope we've got some international people here today. Oh, we've got some from Singapore.
That's beautiful.
Oh my goodness.
I saw someone was in Canada as well. So touching the lives of people in Canada, Singapore, welcome. That's amazing. We're in the United States. We're based out of San Diego, California. And, we are mammography educators, and we provide a tremendous amount of value, of programs, of online education, and just amazing curriculums for people looking to, accelerate and heighten, the state of their professionalism. So, thank you for being on. And I really want to touch on the Miller method, because I feel like that's kind of like our home. That's really where.
Sorry.
Look, we have someone in Bermuda. Amazing.
From where?
Bermuda.
Oh, wow.
Amazing. Okay. So, one of my questions here is why these positioning techniques, that mammography educators puts forward. I know we use a technique called the Miller method. So why do you feel that the Miller method, obviously named after you, is better, as far as understanding the whole scope of what is needed for the skills of mammography?
Well, again, I've been doing this. I started out doing a lot of work with ACR back in the 1990s, and developing, working mostly with Rita Heinlein, developing positioning techniques that were standardized, reproducible, and just everybody was doing the same thing. And I think those of you who have been around that long probably can appreciate that or remember that. There was a lot of support for technologist education. And then it's like at the end of the 90s, like the beginning of 2000, a year before digital was approved, full-field digital in 2001. It's like everything stopped. And it was like, okay, you guys find your own way. And that even I, as a technologist, when I went and started working on digital, it's like, what happened to my IMF? What happened to my PEC down to the P&L? Now, I wasn't getting any of those standards that I used to see. So I really started thinking about, how the equipment changed, definitely. The length of the IR, the width of the IR, width of the face shield, all these things changed. But nobody taught us how to accommodate those changes with positioning techniques. And so I really started thinking about it. I had the opportunity to work with Dr. Laszlo Tabar in Sweden. Some of you guys may know who he is. But Dr. Tabar probably is one of the most famous radiologists in the world because he's published more data on the efficacy of screening mammography than anybody else. And so I know he runs a pretty tight ship. And so he requires a very high quality exam, but also all of his texts position the same way. Well, why do you think that is? Consistency, reproducibility, also too with workplace injuries. And so they have to make sure that these techniques are ergonomically sound. So once we started implementing them here, not only did we see a huge improvement in image quality, but our feedbacks from the techs that we were training would go, oh my gosh, I can't believe how much easier this is. Now, to be sure, it's awkward in the beginning. Every time you learn something new, it's going to be awkward. But I guarantee, try it, you'll like it. And those of you who have adapted it, if you could, put a little note in your comments whether it's something that's really worked for you. We'd love to hear from you.
Absolutely. So you're saying the Miller method is kind of adapted from that method that you had originally seen.
Well, it was like a combination of what I learned with working with Dr. Tabar, what I learned other technologists who were in a leadership capacity here in the U.S. in the 1990s, Rita Heinlein, Debbie Dyball, me, Margaret Botsko. We're doing a lot of conferences out there. And so it was kind of, in the past 10 years especially, I kind of integrated, taken a little bit from all those different techniques and kind of came up with my own. By the way, I want you guys to know it was not my idea to call it the Miller method. I just cringe on this kind of thing. Mikaela can tell you, it's like, I'm not doing live with Louise. That is just, no, I'm not doing it. Right. So my business partner and the gals have, like Mikaela, that are so supportive of our business, kind of forced me into these things. But I guess it's the only way you can describe it, because it's not only the positioning technique, it is the way I teach it. Those who are familiar with the breast map and how we do all that, I don't want you to understand just why and how to do it. I mean, how to do it. I want you to understand why you do what you do. Therefore, you can look at an image and know what you did wrong, or actually look at the patient and know what they're going to look like before you even take the mammogram. So hopefully fix the picture before then.
And speaking of positioning and images, I saw that some people in the comments were asking about really specific things, specific body types and shapes. And, one of our questions is, because some people have different body shapes, I think that they could probably look to our resources working with challenging patients, because we have so many resources on how to work with challenging patients. One person in particular said that they were dealing with back pain and ganglion pain. And so are there anything techs can do to help prevent or improve, pain, injury, and things like that?
Well, one of the things I want you to think about, I don't know about your mom, but my mom was one of those people who was always harping at me, stand up straight, stand up straight. And, it's so cute because my mom's now 97 years old. And I'll tell you, she has the best posture of anybody. She always sits up nice, straight and tall. And I guess, that's where I kind of I always hear my mother's voice, stand up straight. But when I see you as technologists and you're bending and you're going under, anytime you're bending your back from side to side or forward and back is better than side to side. But what I would like you to do, crouching down like this, let's say to do an MLO, what I'd rather see you do is do a squat, use your knees, use the bottom half of your body to adjust your height rather than moving your head and your neck. That causes a lot of unnecessary back pain. Now, one thing, this is kind of a controversial subject, but I don't recommend that that technologists sit down for the MLOs. I just don't. Obviously, there's going to be cases in patients where you have to sit down or you have to sit the patient down, but I don't think it's efficient. And I know in some places where I've gone in as a consultant where they've had a high number of torn rotator cuffs, I didn't even have to go there before I knew what they were doing. What they were doing is they were sitting down for the MLOs and they were pushing up like this, on every single one of their MLOs. So here's something to keep in mind. Every time your elbows go above your shoulders, okay, that's putting stress on your shoulder, okay? So try to keep those elbows lower than your shoulder, okay? So hopefully, that's a good tip that will help.
Thank you so much for that. And I have people in the comment section saying that they're experiencing neck pain, back pain on ID views, hip pain. So what would you say are the most common sources of pain, the areas that people deal with pain the most?
Well, as I just said, shoulders are a big one, and that can be really easily remedied by keeping the elbows down, okay? I always say, I get a patient in this, I get up really close to her and I use my whole body to control her. Okay. So that way I'm not putting so much pressure on my joints. Okay. So I'm turning her with my whole body and then I'm not pushing with my wrist or pushing with my shoulder. Now in response to the person that said that they had some problems with doing implant displacement views, I don't know how you're doing that, but I would recommend sitting the patient down in a stool, okay, and then pulling the breast tissue in front of her implant. So in other words, you're standing behind her, you're pulling that implant forward. And I think it's kind of it was like kind of a well duh for me when I figured this out. In all of mammography, we're constantly pulling forward, but then in the implant displacement view, we were pushing back. And so I never liked the name pushback view because I was afraid we were going to be pushing back breast tissue. So came up with this idea where you sit the patient down, you stand behind her, you put your hands up over in the front of the patient, and then you pull the breast tissue forward off the implant. So when you sit the patient down, that can be really helpful for those ID views.
Wow. Just genius stuff. So we're hearing neck pain. So you gave such a great tip about the shoulder. Do you have a little tip about perhaps the neck, or a little tip about the back or the hip, something that you just notice could work for a lot of different cases?
One of the things we said, a lot of it is the injuries are due to technologist positioning techniques, okay? But the issue is perhaps just as much as improper use of the equipment, okay? I can't you guys, and I catch myself doing it. Every time I want to hit the culminator light, I'm doing this. And when I do that, look at where my elbow is. Look at what's going on with my shoulder. Every time I do that, my shoulder is, potentially putting more strain on it. So guess what? Your foot pedals are right at the bottom of right by your feet, and make sure they're right by your feet. So you can tap that foot pedal in the down compression, part of it, and the light will come on. Don't do that. And so what you have to do is you have to catch yourself it's these little things that build up. Doing this is a big problem. Also, I used to work with a technologist who, it was funny, we would share a room, and I would do a patient, and then she would go out, and she would do a patient, she would come out, I would do a patient and go in. And what I always found is that her foot pedals were like 3 feet away from where I normally had them. And so I went in with her one day and I said, you're going to end up with terrible hip problems because stretching across like this. Put the pedals underneath your feet, okay? And so sure enough, I was the manager then. The technologist comes to me in about 2 months, and she has to take time off to go to physical therapy because she's got a problem with her hip. So the first thing, identify those areas where there's pain. Okay, pain is an indicator. Pain is your friend. It's telling you you're not doing something properly. So pay attention to what causes that pain, and then try to find a way to do something different. And this is where these standardized positioning techniques can be so helpful, because it's It's consistent, it's reproducible, it's ergonomically sound, it's so efficient. It's so efficient. Just like standing on the medial side of the breast for the CC. There's a reason why we recommend all these things, because it's efficient, reproducible, and it's ergonomically sound. So identify those areas of pain, and then say, okay, what could I do differently? Or if you look at some of these steps that we point out, and we have great resources, maybe you can tell them about that, Mikaela, at the end here, where they can find a lot of really good information from us. But I would say identify that area of concern, and then what's putting stress on it. If it's putting stress on it, do something different. And like I said before, like on the MLOs, if you guys are down here doing that, that's going to hurt your shoulders. If you're down there bending like this, well, it's, and you feel the pain in your neck, then don't do that anymore. Do something different. Like I said, do the squat. Put all the efforts in the lower half of your body. Okay. Your biceps, your knees, and kind of, what I was thinking about the other day. I was working with a physical therapist about 6 months ago, and I wanted to show him my positioning technique. We've done this a couple times, but I met this other guy that I really liked, and we brought him in, and he watched my positioning technique, and he said, well, Louise, what you're really doing is you're grounding yourself. And I thought about it, and I thought, you know what? I mean, not to be hippy dippy woo woo woo, but
let's do it, Louise.
when you ground yourself, you're so much stronger. And also grounding yourself in terms of, it's like Wonder Woman, when your patients are, unhappy and saying not so great things to you, I feel it's like you almost have your little shields up going, and when you ground yourself, you're so much more solid. So think about that. Plant yourself. Always. Also, how you plant yourself is important. You want to separate your feet by about 12 inches. And that's something that you want to tell your patients too, because don't want them, how a lot of times I'm tipping over. Well, have them separate their feet. Okay. So I just say, take your right foot and move it to the right, by about a foot, or, separate your feet by about 12 inches, and do that for you too. I think it will make a huge difference.
And that point of grounding yourself, that you are so much stronger, it's because your center of gravity, right? You're supporting this great pillar in the center of your body, you know what I mean? And that you're not like this little pole that's kind of tipping one way or another, and you're using your muscle to compensate. Like, you're all supported and grounded. And I think that's a great point. I think that could work for any and all people, and even, the patients that are having a challenging time staying steady as well. And people were mentioning, you mentioned, instead of using your lower back, how about you use your knees? What if someone's in the position where their knees are not as strong as they used to be?
Again, I wouldn't make any suggestion, and I need to, obviously make clear I'm not a physical therapist, and if you're having any sorts of real problem, you should see, a professional about it. I'm just talking from, general experience, what I find helps. So if you've got specific knee problems, as we get older, I had to have a knee replacement a few years ago, and it made a huge difference. But that happens as we get older. Now, if you're feeling knee pain specifically related to how you're moving when you're positioning, again, I would pay attention to that and see what you can do without. And no, it says somebody here, Shirley, good tip to do them without sitting and kneeling. Oh yeah, never, you guys, never ever kneeling, never ever ever. I've never done on my knees. No, never. You just get a stool and get down there where you think you need to be. But a lot of techs tell me too that they have to get on their knees for an LM and an ML, and I just don't do that. There's a really, really simple way to do them. Just like you do the MLO, slide down, push up. You do the same thing on the laterals. I don't get on my knees. And also, when speaking of laterals, I don't know how many of you guys are a member of the TBI Facebook group. You're a big Facebook group. We have like 2,700 members. Somebody was talking about that they didn't see as much pec muscle and IMF on the lateral view. Well, that's not the purpose of doing the lateral. This is in addition to your screening views. So on your screening views, you should have seen IMF and pectoralis muscle. But on a lateral view, you're just trying to find an area, a point of reference was going to be the nipple line, and view the rest in the sagittal plane. So you don't have to worry so much about pec muscle and IMF on lateral views.
And I'm so curious about this, Louise, because it sounds like this information is so clear and readily available. Why is it that, so many people are having a hard time with standardized positioning techniques? And how did we even get to this point in positioning where it's not standardized and a lot of people are getting injured in their profession?
Well, Mikaela, this is, it's a really interesting topic and certainly one of my hot buttons because I have been trying so hard since the last ACR manual was published in 1999 to try to get ACR and SBI, Society of Breast Imaging's attention about doing an update because things have changed. We all know that, but there for some reason that hasn't been done, and that's frustrating for me. So and that primarily, I think, is a source for a lot of our information. Everything gets referred back to the ACR manual that's now 23 years old. Well, a lot has changed. And so what we've tried to do as a business, and certainly myself as an individual, is to try to teach people that there's a better way. But unfortunately, because there is no standard technique in this country related to mammography positioning, people haven't had the opportunity to learn. And obviously, when you know better, you do better, right? But most techs have not had the opportunity to learn any differently. And because the MQSA, the FDA, ACR, nobody requires hands-on positioning techniques, okay? Hands-on positioning training after you do your original 40-hour training. And who knows, who taught you how to position. Those techniques aren't moving forward in a way that's standardized or really makes sense ergonomically. So we're doing everything we can to try to get the word out. But I just feel bad that more technologists don't have access to this information. And like I said, it's not only
Okay. Sorry, I just missed that last thing that you said because I saw you cut out a little bit on my side.
I said, not only somebody's saying you need to show us, Louise.
No, I know. And people are just so loving you so much. If you're not following us already, please be following us for more because hopefully we'll do more of these lives and Louise will save the day.
Well, the thing I think I would like to explain to you why we haven't done videos so far. Professional level videos are extremely expensive. They're $1,000 a minute. $1,000 a minute. And so in order to have one that you guys can get any credits from, that would be, it would cost $30,000. And then, we want to make this available to people. Yeah. Certainly would, provide them at a minimal cost, but somebody has to be responsible for the initial cost of that video and making sure it's at the professional level that we want it to be. So what we've decided, though, is we don't know when and if that's ever going to happen. So what we're going to do is we're going to kind of bite the bullet and start shooting some video snippets. I can't promise when that's going to take place, but we've committed to doing that because we know how much you need it. We know how much. But in the meantime, what I would like you guys to do is go to our resource page, and we have something that's called the Quick Steps for Mammography. It tells you step by step by step exactly what you need to do. To do a CC and MLO. It's very descriptive, has a little diagram, and it shows you exactly how to do it. So hopefully.
Yeah, it's amazing. It's an amazing free resource that's available on our homepage. If you just go to the Mammography Educators website, it'll pop right up. You just leave your name and email in there, and then we will send you an email with all that information. And Mammography Educators has just done such an incredible job of creating so much free value, so much value to people so that they can be empowered moving forward as a mammographer. And I'm often reminded of all the work that we put in on the mammography initial training. And what might sound kind of weird is, why, if you're already a mammographer, to go take a mammography initial training again, that 40-hour course. But I feel like what's within that course and what we spoke about a little bit, Louise, is that it's an amazing refresher, that it's something that people could still very much get a lot of value out of, even though they already are a mammographer. So do you feel like the mammography initial training program that we just put together would still be beneficial to people that are already mammographers? And, does that cover any of the positioning? I know that there's a section on ergonomics. I know that we have continuing education credits on ergonomics. So would you point people to the direction of any of those courses if you felt like they needed some refreshment?
Yeah, I think we have a lot of different lectures that are available at a very low cost. So you guys can look at what some of those topics are. We have a really good one on ergonomics and just, difficult. Sorry, I keep going out. I would like to mention is that I know a lot of you guys struggle with large patients and patients who have congenital abnormalities. I would really suggest to you is like, you need to stick with the basics. Okay. I always say, don't throw, these are my mother-isms. She says, don't throw the baby out with the bathwater. So you want to stick to your original positioning techniques. But if a patient is much bigger than you, you're going to have to walk around her. Of course you are. Sometimes it takes 2 or 3 steps around a patient. Don't hurt yourself trying to position that patient like you would position another patient who didn't have those challenges. So super, super important to remember that. And I do not have any tips whatsoever for how to get perfect images on any of those patients. I just don't. We know there was a study published in 1993 by Dr. Bassett out of UCLA where he showed after ACR positioning training. Okay, so this was technologists who were working closely with ACR, went out to UCLA and did a positioning training. After they analyzed all the images, only 2/3 or 66% of the images met the ACR criteria or just the basic criteria that we know and measure today. So that means about 1/3 of the time, it's just not going to happen. So I hope that makes sense.
So what I'm hearing is like, be gentle and be reasonable with your expectations on what images are supposed to look like and how they come out.
For yourself too, one of the things, and you guys probably know, all the chatter on QBI is about inframemory fold. It's just like, oh, I want to hit my head, smack my head sometimes, because guess what? You're not going to get IMF on every single person. It's just not going to happen. And I would like to refer you to the data we published in the American Journal of Rankinology in 2017. Again, that's on our research page. Look at the numbers. There's also a diagram on our resource page. It's called Reasonable Expectations. And it tells you, based on data that we pulled from this study, the scientific study, what a reasonable expectation is. And under the best circumstances, with the best positioning, we're only going to show IMF about 70 to 80% of the time. So you can kind of feel good about that. But, I think we're always talking about ACR level quality, where that is not the norm from day to day. It's something we strive for as, perfection, but that's not the norm. You guys know when we're looking for ACR films, you have to look for them for months, weeks, right? Just to find the perfect ones. So, Mikaela, one thing I did want to bring up, and I didn't see, somebody says we need reasonable expectations to stay mentally.
We just did a blog about that. We really did. It was literally called Reasonable Expectations because of, how high of a standard we're all holding ourselves to.
Exactly. One thing I didn't see come up as a question yet is any problems with wrists or hands.
Let's do it. Yeah.
This is a super easy one to fix, you guys. What I see you guys doing is you take your hand like this. You separate your thumb from the rest of your fingers when you're here. Let me stand up here. I'll do a
Here we go.
C, and you do this for your CC. I want you to catch yourself when you're doing that.
Mm-hmm.
Thumb should always be straight, in line with the rest of your hand. So in other words, you're taking your hand like this instead of like this. Look at the stress that's putting on my wrist, okay,
Yeah.
versus this. That is one of the easiest thing you can do. And one of the things I see most often done incorrectly when I'm working with techs. The other thing too is when you do the MLO, so you got the breast here. Good thing I've got breasts, right? Okay. My father said one time, good thing my specialty isn't proctology, right?
Oh my gosh.
So anyways, you're going to slide down, and then you're going to, let me get here. Then you're going to push the breast up and out again with your thumb adjacent to or close to your index fingers. Not like this, you guys, not like that. So if you catch yourself in the act of doing that when your thumb is separated from your fingers, if you have a V on your hand, number one, do like what Michaela's doing. Not like this, do like that. I would say thumbs up, I'm awesome. Thumbs up. So that's how you remember it. Thumb pointing up, not pointing like a V. Also, what happens when you guys do this, you're going to miss the pectoralis muscle is right here at 12 o'clock. So when you do this, you're going to
You're
miss
missing it.
to visualize that pectoralis muscle right there. So
Wow.
that's a super easy fix. And like I said, it's
Amazing.
one of the most common problems that I see techs, techs having. And then, consequently, they develop problems with their wrists.
Absolutely. So we covered shoulders. We covered a little bit of back with using the knees. Do we cover knees? What do we do for the simple, quick fix on the knees if it's not a serious issue?
With knees, I would say, try to use your biceps more than your knees itself, rather that, try to use the strength in your upper, in your biceps. Yeah. And actually your quads, because
Your biceps or your buttocks, like your
yeah,
baby?
but too, I think, just,
Okay.
but, to help you not put so much pressure on those knees.
Gotcha.
But,
And then we covered wrists and hands.
hmm?
And are there any other, issues, even with like feet, do women are standing all day doing this work, are shoes a big thing,
Oh,
are,
I think any mammographer knows you have to invest in shoes. You have
yeah,
to invest in good shoes. And that's just a must. And I think it's always funny within the department. Somebody will come in with new shoes, and it's like, "Woo! Where'd you get those? What kind are those?" Most of us don't hold back in investing in our feet, but we need to invest in the rest of us too by taking care of your hands and your wrists and your shoulders and your back.
Beautiful. And I hear someone saying like do squats to strengthen legs. And I feel like as professionals in any field that our profession is not just compartmentalized by the time we clock in and clock out. It's like practices outside of work really help to strengthen and empower us when we go to work as well. So I think taking care of our bodies, eating well, staying hydrated, those
Mm-hmm.
will also do great things for our body when we are at work.
And you guys too, somebody is saying, do squats to strengthen your legs. Yeah, totally.
Mm-hmm.
Think of how strong your legs are going to be if rather than bending over at the waist, you're squatting down. You're doing quads is what you're doing. And then you're really strengthening, your butt, you're strengthening your thigh muscles, and you're not putting so much pressure on your back or your knees.
Yes, absolutely. And so for a final question, I think, if anyone listening could just make two adjustments, they could really benefit from two changes in the way that they do positioning.
The first would be their hand position. That is the biggest change that they can make. And the second one is to stand up straight and use their whole body to control the patient. Now, I know somebody saying kickboxing. Yeah. I think that, some of you may be uncomfortable about getting that close to a patient. I can tell you, I've been positioning like this for over 20 years, and I cannot remember a time where I had a patient say, "Oh, you're too close," other than the average complaints, when they're unhappy about everything. But I've never had anybody say, oh, you were too close to me, or that felt weird, other than the general mammography complaints. Actually, it's been quite the opposite. I've had people say, wow, you really seem to know what you were doing, and you really seem to, put me where you needed me to be. And that's part of it too. I was working with some techs a couple weeks ago here in San Diego, and we have a very large Hispanic population here, and a lot of them aren't English speakers. And so they were telling me that they're constantly fighting, trying to get these women, in the right place. Well, if you're just doing that with your hands and your wrists and your shoulders, it's not going to be effective. I kind of put my one hand in the middle of the back, one hand on their belly, and move them over with me. So the more you can control them with your whole body, I think the less strain you're going to put on those individual joints.
That's amazing that you just bring this point up, that body positioning and movement crosses language barriers.
Yeah.
I mean, even like there's no dance crosses language barriers, you know what I mean? And there's nothing more, comforting than to be in the hands of someone who knows really what they're doing and they're confident in their craft. And I feel like when you're able to take someone and guide them through this process, it really helps them almost feel more comfortable.
Mikaela, that's a really good point. For a long time, when I first started teaching this technique, some of the girls would go, oh my God, it looks like a dance. And so we started laughing and calling it the mambo. But you really get up there and it's like leading a partner, which is something that most of us as women are used to doing, but we're usually letting the male lead, which I don't know where that started, but anyway, we can take the lead definitely when we're performing a mammogram.
Thank you so much, Louise. This has been such an informative and amazing conversation. And so many people are here and they've been leaving lots of questions and saying lots of comments. And, where can we continue to find your work? I know they can always stop by the mammographyeducators.com website, hit the resources page, and just get a ton of value out of that. But do you have anything coming up? Is anything new for you? I know that we just had this big announcement. So please tell us, how do we connect with you and what's new with you?
Well, again, I'm on the QBI page, that's Quality Breast Imagers, every day. And I'm trying to post, I have been mostly for the most part, posting a case every week. I try to keep up with some of the comments, and there's other very good teachers on there also. So I'm there every day. You can also contact us, on our website. Most of you guys, at the end of every talk I give my personal email, which is Louise at Mammography Educators. I'm a really, really good emailer. So if you email me, chances are I'll get back to you pretty quickly. But yeah, we're always happy to hear your suggestions and comments, and want to kind of keep moving forward and being a positive light, where we all need it, where and you guys are too, to your patients. It all connects together. If we all learn and help each other grow, that's going to help our patients.
Absolutely. Thank you so much, Louise. And I hope we're able to do some of these lives again. I think we might hop over to Facebook to do one over there and to see, which ones people are really preferring. But I'm just so grateful that so many people showed up to this one, and a lot of our QBI people are in here. So thank you so much. That's such a great community too.
I really appreciate you showing up.
Oh, yeah. I mean, there's still 40 viewers. There's still 40 people that are just amazingly inspired by your work. So, if you want to be part of a powerful community of mammography technologists that are dedicated to, elevating the craft and the profession, supporting each other, Quality Breast Imagers on Facebook is an amazing group that's growing and is thriving, and lots of resource sharing. Please follow us on our Instagram page, email Louise, connect with us, and we have just so much to offer. So thank you for being a part of our family. And Louise, as always, what a pleasure it is to talk with you today.
Thanks, guys. Have a good evening. It's happy.
Ta-ta for now. Bye.